Alzheimer's disease is the most common form of dementia, and that's what we're here to talk about today. So the objectives: to review the dementia diagnosis. How do we diagnose dementia? How do we know the treatable disorders that mimic dementia? Know the lifestyle choices that are risk factors for progression of the disease, and to review recent studies about how the way we live affects that progression. So 10 warning signs of Alzheimer's disease. Memory loss that affects job skills or activities of daily living, difficulty performing familiar tasks, problems with language, disorientation to time and space, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in mood and behavior, changes in personality, and loss of initiative. And each of us has probably experienced something like this at one time or another in our lives, but what it comes down to is how is it impacting your day-to-day life? When you stay up all night studying for a test in college, maybe you don't recall things quite as well as you would have previously. But if this is a daily occurrence, if this is getting worse and not just related to one bad night of sleep, then that's something that is much more clinical. So what is dementia? It interferes with the ability to function. It's a decline from previous levels of function. So when someone comes into my office and says, oh, I can't remember names, but I've never been good at names. Well, we need more information on, well, are you worse at names now than you were before, or is this just part of who you are? It's not explained by delirium or a major psychiatric disorder, and it's cognitive impairment from history and objective exam. Now, the history taking, this is very important, needs to be from more than the patient. I can't tell you how many patients come into my office for memory impairment, and they're the only ones there. And they say, well, my memory just isn't right. Okay, well, give me some examples. Well, I can't remember the examples. So having a family member there who is familiar with the day-to-day interactions is extremely valuable. And I would say I'm hesitant, if not completely unable to make the diagnosis of dementia unless there is an alternate history giver there. So cognitive domains. This is one of the ways that we determine what kind of dementia is going on and whether or not dementia is affected. Alzheimer's disease has several different cognitive domains that can be affected, but dementia, which is the overarching diagnosis, Alzheimer's disease is one form of dementia. So that's what the difference is between those two. But any type of dementia has to have at least 2 cognitive domains involved. These cognitive domains involve the difficulty acquiring and remembering new information. Okay, if they're asking the same questions over and over again, do not remember the names of people that they met recently. Difficulty reasoning and handling complex tasks, planning meals, or planning, paying the bills, or balancing the checkbook. Visuospatial function, recognizing objects, operating them. I can't figure out how to work the remote control. Language function, difficulty thinking of common words, although this is very nonspecific, it can certainly be a part of it. Difficulty getting words out is yet another condition, another symptom of something, a type of dementia, but it's a little different from Alzheimer's disease. And then personality and behavior impacts. When someone is apathetic or someone is behaving in a way that is completely unlike themselves, when they are making bodily noises in public, or when they're usually very polite and they start cursing at the pastor, those kinds of things are signals that there might be something wrong. They're not just trying to upset you. So probable Alzheimer's is an insidious onset. It's slow and progressive. When I ask people, when did these problems start? Oh, well, I'm not quite sure when they started, but I would say it was about 2 or 3 years ago. worsening cognition by report or by observation, and then the presentation of Alzheimer's disease is usually either amnestic plus another cognitive domain, word finding difficulty plus another cognitive domain, visuospatial is another common presentation, and then executive functions plus another cognitive domain. So an exclusion, how do you know that your family member does not have Alzheimer's disease? This is less likely in people who have a stroke and they're just not the same after that. That's more consistent with a type of dementia called vascular dementia, which we're going to talk about a little bit later. But vascular dementia is multiple small strokes that cause enough damage that the brain just doesn't work right afterwards. And the progression of vascular dementia is one where they plateau and then decline, and plateau and then decline, and plateau and decline, whereas Alzheimer's disease is much more of a slow and gradual decline. Another exclusion for for Alzheimer's disease is features of Parkinsonism. Another common form of, so Alzheimer's disease is the most common type of dementia. Vascular dementia is the second most common, and third is dementia with Lewy bodies, which involves a lot of the signs and symptoms of Parkinson's disease. It also has hallucinations. Frontotemporal dementia is less common. People are younger at the onset of frontotemporal dementia, and it's more focused on personality changes, which is what the frontal lobes usually are most involved in. Primary and progressive aphasia is a condition that is pathologically, if you take pieces of the brain, it looks like Alzheimer's disease sometimes, like frontotemporal dementia sometimes, but the symptom is inability to speak. So that the memory is maintained and things of that nature are maintained, it's just they can't get the words out. And the struggles with people who have this disorder are mainly verbal in nature. And also, exclusion for Alzheimer's disease is any other disease that could explain the issues. So the bottom line in my work, I cannot diagnose Alzheimer's disease with a single scan, a single conversation, and especially not during a hospitalization. So someone comes into the hospital, they're not going to be at their best, and I don't want to diagnose dementia unless I am seeing them at their best and testing them objectively when they are well rested, when they are feeling well. I have people come into my office frequently who say, I had an MRI and it showed that I have dementia. And that just can't be. It can show an MRI that is consistent with dementia. It could show atrophy, shrinkage of the brain. It could show scarring that can be consistent with dementia as well. But an MRI cannot diagnose dementia. It is dementia or Alzheimer's disease. It is a diagnosis that has to be done with a clinician talking to a patient, preferably when they're at their best. You need information from several different sources, labs to rule out mimickers and aggravating factors, patient reports, as well as family corroboration to build a timeline to see if the timeline looks more like vascular dementia or Alzheimer's disease or frontotemporal dementia. What symptom happened first is oftentimes a very important question. Brain imaging is very important. It's not the only thing, but it is important in the diagnosis. It is important in seeking the cause. And then observation of points over time. Diagnosis is important and prognosis is also important, and that can vary based on the individual. So what if it's not Alzheimer's? I'm going to go over briefly what the other things are that could be going on. So mild cognitive impairment might be something that you all have heard about. Mild cognitive impairment is, if you go back to those cognitive domains that we talked about, you have to have two domains affected for it to be dementia. If only one domain is affected, if you only have problems in one realm of thought, in one realm of cognition, then that is mild cognitive impairment. Also on objective testing, you test a little bit below normal, but not hugely below normal, okay? So the test that I do is the Montreal Cognitive Assessment, and if somebody tests 23 to 26, I'm more likely to think that they have mild cognitive impairment than if they test 15 and below, okay? Mild cognitive impairment is important. There is no interference with ability to do daily activities. These are the people who are just like, my mind doesn't quite feel right. Oftentimes there's good insight. I'm not remembering as well as I should. The history from the patient and knowledgeable informant are essential. Sometimes I will have someone come in and say, my memory isn't right, my memory isn't right, and a family member comes in and says, I have seen no changes in behavior, I have seen no problems, and it turns out that the memory testing turns out just fine, that there are no cognitive changes. If that's the case, that's a blessing and I can provide some reassurance, but I certainly want to repeat the memory testing in 6 months to a year to make sure that they are not just seeing things earlier than we do on our cognitive tests. So screening for MCI, Peterson is a neurologist at Mayo Clinic, and I had the privilege of working with him on a rotation in medical school, which was an awesome experience. But he kind of developed this idea of mild cognitive impairment. And he did the studies in 2001 that showed that there is no evidence that screening everybody who is over 65 is helpful. Just because you hit 65 doesn't mean that miraculously you're going to need to be screened for memory problems. However, if you are experiencing memory problems and you do get screened and you end up with mild cognitive impairment, you need to be followed over time. The risk of developing and progressing into Alzheimer's disease with the normal population is about 4% per year, and mild cognitive impairment increases that to 25% per year, okay? There is a scan that can also increase our evaluation of whether or not this will progress. Unfortunately, it's a scan that is considered experimental and insurance won't pay for at this point. And that's understandable because that particular scan, if I tell you that you're going to progress to Alzheimer's disease, but I don't offer you an option, if I don't offer you something else that needs to happen, I don't offer you a treatment for it, how important is that information? And so that's what our research is working on right now is, okay, we'll identify it early, but then what's the next step? What's the treatment? So why is it important? The sooner we learn about the patients with mild cognitive impairment, the sooner we can put them on acetylcholinesterase inhibitors, okay? Acetylcholinesterase inhibitors are like donepezil and rivastigmine and things of that nature. These medications do not prevent the disease, they do not stop the disease, they do not change very much, but they do help slow the disease process. And we know that when someone has mild cognitive impairment, the idea is to put them on the medication to maintain as much brain as we can. Lifestyle changes is another big reason. It may make a huge impact in this particular population. So an MRI of the brain is a scan that we get most often. If you look here, there's a little bit of atrophy, not very much, but here, these scars, the way I describe it to my patients is that everybody, as they get older, they develop scars on the skin, and they also develop scars on the brain. This is a very typical MRI of someone with Alzheimer's disease, but it's also very difficult to separate this MRI from someone with vascular dementia, which is why the history is so important. So vascular dementia and AD is a hot topic of research. It's more of a spectrum than it is a different diagnosis. Strokes seem to the thought was that strokes would put you at higher risk for Alzheimer's disease, but what they actually found when they did some of the scans looking at amyloid, which is the protein that is deposited in the brain, the stroke burden, those scars that we saw on the MRI just now, those had more of an impact on memory than the amyloid scan did. And so if the more scars someone had, the worse their memory was, which means A, once you've got the scars, there's not a whole lot that we can do about it. But B, if you adjust your risk factors and try to avoid developing the scars, you're more likely to be effective as far as slowing the progress or preventing dementia entirely. That's logic. That's not backed up by a whole lot of studies, but that's just where the information is going right now. And we still have a lot to learn. So clinical consequences. What does all of this mean? It means we need to manage the stroke risk factors, especially in dementia, in vascular dementia, but even in Alzheimer's disease. Managing your stroke risk factors are huge. Smoking cessation is very important. High blood pressure control is very important. Cholesterol, diabetes, there's even one study that they are doing where they give intranasal insulin, and they are finding that people's cognition improves after receiving intranasal insulin, even if they don't have diabetes. So what that interplay is a very interesting topic of research as well. Whitmer and colleagues showed 20 to 40% increased risk of dementia, not necessarily Alzheimer's, in patients with all of these risk factors. Atrial fibrillation is one that has not been covered in very many studies, but if you have atrial fibrillation, there is a way to determine if you are a candidate for anticoagulation. And even if it's not a dementia risk, it is certainly a stroke risk, which is bad enough. Okay. Parkinson's-related dementias are yet another category. Movement symptoms usually occur before the dementia in Parkinson's disease with dementia. Some studies indicate 20% of patients with Parkinson's disease have mild cognitive impairment at the time of diagnosis. But it's not something that we pay a whole lot of attention to because we're so focused on treating the symptoms of tremor and stiffness and gait instability. But it is something to be aware of. Dementia with Lewy bodies is yet another disease. Both of these diseases look similar when you take pieces of the brain and look at the underlying structures. Alpha-synuclein is the deposit. It's a deposit of alpha-synuclein rather than the amyloid protein that we see in Alzheimer's disease or the tau protein that we see in frontotemporal dementia. The diagnostic criteria for the Parkinson's disease dementia is the presence of dementia, at least 2 of 3 core features, fluctuating attention and concentration. One of the things that we see in Alzheimer's disease is attention is usually good. They just can't put the things that they learn into their long-term memory. But with dementia with Lewy bodies and Parkinson's disease dementia, attention is scattered. Recurrent and well-formed visual hallucinations, and then Parkinsonism, which is stiffness, short, slow steps, and tremors. Suggestive features are REM behavior disorder, which is acting out the dreams, and another type of a scan called a DAT scan that shows reduced dopamine uptake. Another feature of this particular disorder is that if someone has behavioral abnormalities and they are put on antipsychotic medications like Haldol or Seroquel even, or any of those types of medications to try and control some of the behaviors, they can get worse or they can develop much more significant Parkinsonism where they can barely lift their heads up or they can no longer walk. So that's another red flag that we might be dealing with one of these disorders. Again, red flags for Lewy body dementia, hallucinations. Sometimes they're not particularly bothersome. I had one patient who spent his afternoons talking to China shepherdesses in his living room. And he was perfectly happy and content to do that. With these types of hallucinations, especially because people are more sensitive to neuroleptics, we do not treat the hallucinations unless they are bothersome to the patient. So seeing monkeys crawling on the china cabinet is not necessarily something that we treat, but if the patient goes after the monkeys with a broom, then we need to do something about it. Extreme sensitivity to antipsychotics, as I mentioned. Propensity to delirium. So delirium, just to back up a minute, dementia is a slowly progressive disorder of memory, usually. Memory, behaviors, cognitive functions. Delirium is an acute issue. It is something that will happen in the hospital. It can be triggered by multiple different things. If the meds aren't right, pain medications, surgery, anesthesia. If any of y'all have loved ones who have been in the hospital and start screaming about how the nurses are trying to kill them, that's encephalopathy or delirium, okay? So in dementia with Lewy bodies, they are much more sensitive to these things that can trigger delirium, and delirium is triggered by much more, okay? The other thing that we see in any of the Parkinson's dementias is autonomic dysfunction. They stand up and they get lightheaded. Their blood pressure drops. Their heart rate is up and down. All of those things are impacted by these dementias as well. Repeated falls are something else to look out for. So treatment and prognosis for dementia with Lewy bodies. Some people respond to acetylcholinesterase inhibitors. I just received word about an article that talks about the different ways to treat the symptoms of dementia with Lewy bodies. Some people have a paradoxical response. Rivastigmine apparently has the best evidence for it. And some people need antipsychotics, but we need to keep them to a minimum, and I prefer to use quetiapine or Seroquel if at all possible because of the low dopamine effect and the more sedating effect. So a little bit of dopamine at night, or a little bit of quetiapine at night can sometimes be helpful without aggravating symptoms. And then Parkinson's disease with dementia, it's symptomatic management. It usually progresses more quickly than regular Parkinson's disease from both a motor and a cognitive standpoint. So how do you really tell? Get a neurologist involved, or neuropsychiatric testing, or both. I mean, neuropsychiatric testing is anywhere from a 4 to 8 hour test that really gets down into the nitty-gritty of what parts of the brain are affected and can make the difference between the diagnosis of Alzheimer's disease and vascular dementia and Lewy body and other things. So the list of somewhat reversible causes, I say somewhat because once you have a disorder that has affected your memory enough, there is a chance that it can improve but never completely go back to normal. So there's no guarantee that there's going to be complete reversal even in these conditions, but these conditions are things that I always look for because they are much more easily treatable. Low thyroid. If you have low thyroid, making sure that you're on the right dose of thyroid medication. B12 deficiency, thiamine deficiency, normal pressure hydrocephalus, which is a condition where the fluid that bathes the brain puts pressure on the brain and causes difficulty with walking, difficulty with memory, and difficulty with, difficulty with walking, memory, and continence. Paraneoplastic syndrome, so some types of cancer will release an antibody that attacks the brain. And then depression, which is also known as pseudodementia. Some people don't realize that depression can be just as impactful in the memory, especially the concentration, as Alzheimer's disease. Sleep apnea and seizures. So tests that I always order: CBC, electrolytes, glucose, BUN and creatinine, B12 levels, liver function tests, and thyroid function tests. Most of the time, the primary care doctor has already done this, or at least some of them. But these are the things that I don't want to miss. These are the things, if anybody comes to me with a memory impairment, I will get blood work and I will get these things just to make sure that we're not dealing with something mimicking dementia. And I almost always get an MRI unless there's a good reason not to. So people will talk to me about, oh, I'm too claustrophobic for the MRI. I will knock you out. I will do whatever I need to do. But we need to get a picture of the brain to make sure that there's not something like a tumor, a benign tumor like a meningioma putting pressure on your memory centers. Those kinds of things, again, are treatable. Warning signs, things that I look for that indicate that this is not Alzheimer's disease. Again, age less than 55 at onset, rapid onset and progression. Systemic signs and symptoms like the blood pressure dropping or high blood pressure. A history of cancer. Difficulty with walking is not usually something that Alzheimer's disease is common in Alzheimer's disease. Significant behavior changes. Focal exam where they can't move one side of the body or they can't feel on one side. And then anything that twitches usually is something I look at askance. So case number 1 is a 68-year-old man with progressively worsening memory difficulty. His Montreal cognitive assessment is 23 out of 30. Snores like a freight train, and an Epworth sleepiness scale, which is a measure of how sleepy he gets during the day, is 12. Sleep study revealed obstructive sleep apnea, and the memory improved over months to years with treatment with CPAP. So CPAP is continuous positive airway pressure. And sleep apnea is a condition where when you go into REM sleep, your brain has to disconnect from your body because your brain is acting like you're awake, but your body is healing and needs the sleep, and so it paralyzes your body. When it paralyzes your body, your throat can close up. Those people with sleep apnea, their throat closes up, and so they have to wake up to take breaths. They have to reinitiate that tone, and that can lead to some difficulties with changes in your heart that increase the heart attacks, changes in your brain that increase stroke risk. All of these things, high blood pressure that's difficult to control. Things that you need to look for that might be signals that your loved one has sleep apnea. If the bed partner is observing loud snoring or apneic episodes, resistant high blood pressure. You're on 3, 4, 5 blood pressure medicines and your blood pressure is still elevated. Reflux disease. So if you wake up and you've got that icky taste in your mouth and you can't get rid of the reflux no matter how many meds you've tried, headaches when you first wake up in the morning, I can't sleep, and increased risk of stroke and heart attack. So whenever I see anybody with a stroke or a heart attack, sleep apnea is always on my list of possibilities. Memory disorders as well. Case number 2. A 77-year-old lady admitted for failure to thrive. She was refusing to eat. Progressive memory deterioration over the last 6 to 12 months. Her Montreal cognitive assessment was 21 out of 30. And she breaks into tears when asked about her family situation. Neuropsychological testing, and this is one of the reasons that we get it, reveals a deep depression. It improves over months with counseling, antidepressants, and psychiatric support. Counseling and antidepressants together are much more effective than either one separately. I see tons of people on antidepressants. When I bring up counseling, not really interested. It's not that bad. It's bad enough for me to put a chemical in my body, but not to talk to another human being about it. I would love to put all of my patients into counseling. I think counseling is extremely important, just to have somebody objective who is not involved in your situation that you can talk to about, that you can spitball with about ways to improve your situation. So I'm a big believer in counseling, surprise. But it's something that is an essential part of treatment of pseudo-dementia, okay? Screen for depression involves something called the Geriatric Depression Scale, and ask family members and the patient about their mood. How are you feeling? It's sometimes hard to bring up this subject, but it's really important. Neuropsych testing, if they don't believe me that they might be depressed. And you can find this on your own, or it can be a strong comorbidity. So patients with dementia who have depression on top of it are not going to do well unless and until we get their dementia treated, or sorry, the depression treated. Depression can make quality of life much worse for patients with dementia. Case number 3. A 54-year-old man starts having unusual behaviors, acting out over the course of 6 months. Then he develops difficulty with his gait, difficulty remembering appointments. Montreal Cognitive Assessment is 15 out of 30 and can't concentrate for most of the questions. Asks me to repeat the questions over and over again. Excuse me. Outcome number 1, workup includes an anti-Hu antibody, which is a paraneoplastic antibody, and the MRI showed that parts of his brain are lighting up bilaterally, which indicates that it is a systemic disease. CT of the chest, abdomen, and pelvis shows a ditzel. Ditzel is just a word for something that looks like a little dot. Biopsy of that ditzel shows small cell lung cancer, which is treated and he recovers. So people who have paraneoplastic disorders that lead us to their cancer early are more likely to do well because it lets us catch the cancer when it's younger than we would have otherwise. Outcome number 2, MRI of the brain shows enlarged ventricles out of proportion to the mild cerebellar atrophy. Gait stabilized significantly within 30 minutes of a large volume spinal tap, indicating a diagnosis of normal pressure hydrocephalus. Treatment for this is shunt, but many times the symptoms are not completely reversible. The sooner we get the shunt, the better off people are. Over the next several months after shunting, mentation improved, but he did not get back to baseline. Case number 4, a 54-year-old woman with a history of depression develops psychosis fairly rapidly, vivid images of the floor dropping out. She spends a lot of time screaming because she is afraid she is going to be pulled into hell. Various stereotyped hallucinations. It's the same thing every time. The floor drops out. I'm going to be pulled into hell, I'm going to be pulled into hell, I'm going to be pulled into hell. She was sent to the psych hospital with thought that this was depression with psychiatric, depression with psychosis. Turns out, a neurology consult was obtained and she received an EEG that showed every time that the floor dropped out, she was having a seizure. So these were seizures that were leading to behavioral abnormalities and what appeared to be psychosis and could have been thought to be dementia as well. So always one of our jobs is to remain interested and remain curious and remain asking questions about, is this the correct diagnosis? Driving. I'm taking a little bit of a bypass here to talk about some new laws. Just in the last couple of years, the state of Texas has revisited their driving laws, and dementia is taken into account. So previously, dementia had, there were no laws on what to do if your loved one is driving, what the state of Texas wants to do if your loved one is driving with dementia. But now there are. So the clinical dementia rating scale is something that we use to evaluate this. It lets the caregiver give us an idea of how bad the dementia is, okay? How much it impacts their activities of daily living, how much it impacts their ability to function. Those with test scores of 0.5 to 1 have variable levels of ability to drive depending on other things, and we'll show you those in a minute. Self-report, when a patient with dementia says, I can drive, I'm fine, I haven't had any problems, that's not particularly the most objective measurement. Unfortunately, people are not very insightful into their own ability to drive. However, caregivers' assessment is sometimes helpful. Okay? Reassess every 6 to 12 months. This is not just a check the driving out and then they can drive forever. This is every 12 months I have my patients go through a driving test once we have determined that they have dementia. Assessment of a driving risk. These are some of the risk factors. History of citations, crashes, driving less than 60 miles a week. If you drive less often, you're more likely to have problems. Situational avoidance, aggression, and impulsivity, and a mental status exam less than 24. So those are all, the most evidence is basically that a caregiver says, Dad shouldn't be driving, or my wife should not be driving anymore. That's the most evidence that we have. So the clinical dementia rating scale is this. It is an evaluation of how much they are affected on several different cognitive domains: memory, orientation, problem solving and judgment, how involved are they in the community, home and hobbies, and then personal care. So those are the ways that we evaluate how much the dementia is impacting the patient. Driving evaluation can take place in one of several different ways. Good Shepherd Occupational Therapy Program has a driving simulator that I've just recently heard about and have not been able to get anybody to go to Longview to take yet. But I'm very excited about it, and one of these days I'll get over there and tour. Dr. Barry Rath does a tabletop driving simulation. AAA Driving Academy in the Green Acre Shopping Center does driving evaluations as well. And there's always going back to DPS and saying, I need to take a written and a driving evaluation. That has worked and is probably the most reliable of the things, because if the state of Texas tells you you can drive, then they shouldn't need to take your license away. So what can I do to prevent and slow the disease? That's the big question, isn't it? Control stroke risk factors. Doesn't matter what kind of dementia you have, especially Alzheimer's disease and vascular dementia, you need to control your stroke risk factors. High blood pressure is the one that has been the most associated with stroke. It's the biggest risk factor for most people for stroke. It's also a huge risk factor for progression of dementia and Alzheimer's disease. Quit smoking, please. Quitting smoking is huge. Stay active, clean eating, sleep well, and manage stress. Okay? So there really aren't any pills that I'm going to be talking about here. High blood pressure. Biggest stroke risk factor. Risk of dementia increases with midlife high blood pressure. We're not so sure about the late life onset of high blood pressure. Low blood pressure can also contribute to risk, so you need to work closely with your primary care to make sure that it is controlled, but not too well controlled. So we don't want somebody dropping the blood pressure so low that they pass out or feel terrible, okay? I have heard many people say that I don't take my blood pressure medicines because they make me feel terrible. Talk to your primary care about it. Don't just stop the medicines, but talk. The interaction between a patient and a primary care doctor is so very important, because the primary care doctor is your advisor for health and well-being and everything in life, but the primary care doctor can't make you take your medicines and needs to know if those medicines aren't working for you. Logically, uncontrolled blood pressure leads to more scarring, which leads to more challenges with cognitive processing, but it's very difficult to develop a study to prove that. Work with your primary care. If you haven't heard it enough, quit smoking, quit smoking, quit smoking. One study reported doubled risk for Alzheimer's disease when people smoke. Please, please, please. It takes work. It's hard. There's no doubt about it, but it's totally worth it. Stay mentally and socially active. So I don't know if y'all have heard this before, but the nun diaries. One of the things that there is a particular group of nuns, I'm not sure if all nuns do it or just this one group, who journaled. It was a requirement that they journal when they went into the monastery. And so this one group of nuns donated their bodies and their brains to science when they died. And what they found when they looked at the journals of the nuns, when they looked at the brains of the nuns, was that the nuns who were journaling had a decreased incidence of Alzheimer's disease. Even nuns who had severely atrophic brains had very minimal symptoms. And the thought was that because they kept their brains active, because they were cognitively involved, because they were journaling about intellectual pursuits, those types of things we think are protective. And that's where some of the research is going now, looking for neuroprotection and what kinds of cognitive pursuits are going to be the most protective. We don't know. We just know that if you use your brain, you're less likely to lose those cells. Cognitive reserve is the name of that theory. Higher levels of education, people with higher levels of education are less likely to get Alzheimer's disease. Recent research showed that formal cognitive training was protective. Memory, reasoning, and processing speed, the people who went through this training were less likely to develop dementia than the people who didn't. And so we know that using the brain, trying new things, staying on your toes in a cognitive sense is helpful. Training programs are still experimental, not for prime time. I will let you know when I find out when we can bring them to Tyler. I'd love to have a program like this. I think it would speak very well for getting the community behind it, and I think it would work really well in this community. Getting involved. Try something new. Tyler Area Senior Citizens Association, which I just found out about the other day, has, it can teach you dominoes. Yes, you told me. They can teach you about dominoes. They have exercise classes. They have a community that you can join that can be really helpful. Wonderful Wednesdays with the Alzheimer's Alliance of Smith County is more focused on patients who already have a diagnosis of dementia, but can also be very helpful for both patients with dementia and their caregivers. Church groups, assisted living programs. If you live in assisted living, especially one with memory care, a lot of times they have programs to stay mentally and socially active, because we all are aware that this is a really important part of care for patients with dementia. Dementia is your motivation to exercise. So, exercise, some motivation is required. There was a study that showed that people who are physically active, older adults who are physically active, improve in strength and fitness, but also improve in cognition and behavior. So getting out there and exercising is really important. So what do you mean by exercise? What's your favorite exercise? Sudoku. Yoga, Pilates, walking, cycling, swimming, dancing, rumba, zumba, whatever you want to do. Get out there and physically move. It activates parts of your brain that nothing else does. So you need to stay physically active. Do it to music, do it with friends, do it outside, just do it. Just do something. Walking as a family, just walking 30 minutes or walking 15 minutes twice a day. Something along that line. A healthy diet. So there has been a lot of question about what is a healthy diet. The real food pyramid, these are the foods that we're talking about. Real foods, not processed foods. So fruits, vegetables, lean meats, olive oils, coconut oils. Avoid processed foods. Anything that comes in a box or a bag is not what you need to be aiming for. When we're talking about learning how to do new things, learn how to cook. If you already know how to cook, learn how to cook different recipes. Investigate ways of putting more fruits and vegetables and less processed foods in your diet. If you need a diet with a name, Mediterranean diet has the best best evidence for it. This is not just pasta and red wine. It's cooking with olive oil. It is lots of fruits and vegetables. It is lots of fish. And occasionally red wine and dark chocolate, which is one of the reasons I like the Mediterranean diet. Low glycemic index treatment is something else. It is more effective. It's very effective for epilepsy, but we're starting to realize that low glycemic index treatment is also a diet that is helpful for dementia and Parkinson's and other things. Paleo is a buzzword that you've probably heard, and it's hard to know what paleo means, but again, lots of fruits and vegetables, avoid processed foods. If I can tell you something to do with your diet, lots of fruits and vegetables and avoid processed foods. Omega-3 fatty acids and B12 also seem to play a role. Jury is still out on supplements of that nature. Sleep. Medications increase the risk for morbidity and mortality. Medications to help you sleep. Okay? Anticholinergic compounds like diphenhydramine, Benadryl, and Ambien can make Alzheimer's disease worse. Sleep is essential to the quality of life. We all feel terrible if we don't get sleep. So what do? Sleep hygiene. You can look that up. That can be your search. Look at whatever search engine you like. Sleep hygiene is what I would suggest to start with. Some people still need medication to help them sleep, but let's start with something simple. Have a regular routine. Try to avoid bright lights for at least 1 hour prior to bed. Keep the bedroom dark. Not so dark that you trip going to the bathroom in the middle of the night, but dark. Nothing in bed but sleep and sex. Don't read, don't watch TV, don't play on your phone, don't play on your iPad. Just sleep and sex in bed. If you are tossing and turning, don't stay in bed. Get up, go to a different room, read the most boring book you've got in the house. Leviticus works well, although it's kind of depressing. If you are not interested in cars, read your husband's car magazine. If you're not interested in knitting, read your wife's knitting magazine. Go read something that is not going to interest you or intellectually challenge or stimulate you. Listen to calming music. Write down the racing thoughts and worries that are in your head to get them out so that your brain can do the business of sleep. Your job is to sleep at night, not necessarily to do whatever it is, the million things that you have on your list of things to do. Stress management is something that you need to practice daily. Stress is an unavoidable part of life. You can only adjust how you respond to it. You can't adjust the intake, you can only adjust the output. Exercise is a really good way of doing this. Walking, yoga, spending time with yourself. Playing with pets, prayer, meditation, confession, breathing, journaling, whatever it is, it's different for everybody. Whatever it is for you, find a way to let that stress go, because that stress is not helping your quality of life, and it's certainly not helping your risk for dementia. Resources, there are several. Alzheimer's Alliance of Smith County is a huge resource that we have in this area. Alzheimer's Association is another good resource for information. TASCA.org is the Tyler Area Senior Citizens Association. UCF Memory Center and the Mayo Clinic also have some good input. Caregiver stresses are huge, as the Alzheimer's Alliance is aware and is bringing the speaker in. The 36-hour day by Mason Rabins is a good thing for caregivers to know about. Caregiver.org is another source. Home health can focus on palliative therapy instead of curative therapy, which is not something that all the home health agencies get. Address sleep and behavior issues early and beware of caregiver burnout. Use the respite services. Whatever you need to do to work with your doctor to find a way of making life livable is really important, okay? And find a doctor who can help you support the hard decisions. Is it time for an assisted living? Is it time for a skilled nursing facility? It is not something that a lot of people want to face, but it is a reality that as dementia progresses, loved ones are less and less able to take care of the patients at home. And so just be aware of that, that it's not any failure of yours as a caregiver, it is an effect of the disease. So start medication early. As far as rivastigmine, donepezil, Namenda, those kinds of things. Stay physically, mentally, socially active. Control your stroke risk factors. Clean up your diet. Work on your sleep routine. Manage your stress. Take care of the caregiver. And then test for driving ability, I think. And laughter is the best medicine. Those are my kids. Thank you.